I'm Sid Smith from the University of North Carolina, and I'm here with Mark Huffman and Donald Lloyd-Jones from Northwestern University. We are attending the American Heart Association Scientific Sessions in New Orleans, where there has been a very interesting program presented on risk reduction strategies on a global stage. As you know, cardiovascular disease is now the leading cause of death and morbidity in the world, and major efforts are underway to reduce this toll, this burden of cardiovascular disease. These all center around strategies to reduce the risk of events or the occurrence of risk factors. So these presentations today have the potential for major impact in moving the ball forward in our strategies to reduce the burden by the year 2020 or 2025, depending upon which group that you're working with or looking at. Mark, you chaired a session this morning on risk reduction strategies. Could you summarize a little bit some of the major findings?
You bet, Sid. Thanks. Dr. Ron Peters and his group from Amsterdam did a clinical trial looking at the effect of a multi-level intervention among patients who'd had a recent acute coronary syndrome event or coronary stenting. And he was looking at how to improve health behaviors. Many of our patients try to lose weight, try to get more active, try to stop smoking. And so Dr. Peters and his colleagues actually plugged in with programs like Weight Watchers, Philips Direct Life, and Look Signal, which is a Dutch tobacco cessation program. And over a period of about 18 months, compared with usual care, the participants randomized to the intervention demonstrated an improvement in overall lifestyle risk factors. So it's exciting to see some strategies that can help our patients improve their cardiovascular health. I think some of the questions related to that will be, how much will it cost, how to sustain some of these programs.
Were they comparing one program versus another, or was it the use of the combined programs at 6 months? You have data for follow-up.
Correct. It was all three, actually, and the participants had the opportunity to choose which one or ones were important to them so that they got to drive the bus a little bit, not just the doctor, not just the nurse.
So funding may be a big issue here. Program was done in Europe.
Correct, in the Netherlands, right.
Okay.
And Sid, I would add that the major driver of improvement seemed to be people who lost weight, interestingly enough. There was no improvement in physical activity scores or 6-minute walk distance, and no improvement in smoking cessation, interestingly enough. So it was all about people who at about 6 months had lost 5 kilograms or more. So sustainability is another question. And there were a fair number of missing individuals by the end of follow-up. So we're not sure if those were perhaps the heavier individuals. So always caveats with clinical trials, but I think that that this looked like a promising intervention and maybe good news for Weight Watchers, who were the partners on weight loss.
Oh, so the issue of weight reduction, of course, we got into this at NIH with the guidelines and the whole issue of exercise, which I fervently support. But really, it's the diet that is the major driver of weight loss in most situations.
Often true.
And then you get into the situation where people who would rather continue to smoke say, I do that because I think it keeps my weight down. So there's a very interesting observation.
Yeah.
But Weight Watchers seems to be what's coming out of this.
Well, that was the partner they chose for their weight reduction program, and it wasn't cheap, but it seemed to be effective in the people who maintained in the trial.
Mark, you have a couple other studies.
Yes, I do. So, Sid, the next one, Dr. Jung He from Tulane University here in New Orleans, worked with partners in Argentina to try and improve blood pressure control. Anywhere from 25 to 30% of adults globally have raised blood pressure, but treatment and control rates are really, really low, about 10%, so only 1 out of every 10 people in low and middle income countries. So Dr. He and colleagues performed a cluster randomized trial of public clinics in Argentina, randomizing them to a multi-level intervention that was based upon algorithms, home blood pressure monitoring, even some mobile phone text messaging between the providers and the patients compared with usual care. And again, this was at 18 months for outcomes related to systolic blood pressure. And there was a substantial reduction in both the intervention in the comparator groups, but an even greater reduction in systolic blood pressure by about 5 to 6 millimeters of mercury in the intervention group. So pretty exciting. It's great to see them working in a low and middle income country in public health clinic settings. I think, again, this question about sustainability is going to be pretty important to think about how could you scale this more broadly. But seems to be pretty exciting work.
And mobile technology, what type of things are they doing?
So some text messaging between community health workers and nurses and patients related to health behaviors that influence blood pressure, as well as adherence to medications.
How frequently were they monitoring blood pressure? Were they doing it at home? What was the approach there?
Great question. I don't think the investigators had enough time in the 15-minute session to talk about it. I know they did report results at 6, 12, and 18 months, but I'm imagining there was some of that deeper dive into the data will be important to understand what are the key ingredients that can be scaled to other places in Argentina and other low and middle income countries.
Yeah, I think these are impressive findings in terms of the reduction in systolic pressure, and they are being seen in a developing economy, a country with a developing economy. We're not talking about Europe or the United States. Very important.
Yep.
Potentially very helpful.
Yep.
I think something interesting about this one as well was that even in the usual care group, as Mark pointed out, the improvement in systolic blood pressure was pretty substantial. And these were all hypertensive patients at the beginning, 90% of whom were already treated. So the usual care group saw a further reduction of 13 millimeters of mercury, and about 50% got intensification of their therapy in the usual care group. And then the intervention group saw about a 19 millimeter mercury reduction. So that was what drove the power for the significant finding. But I think it gives us some hope that even just people being aware that a blood pressure monitoring is going on drove better care.
Absolutely. You're getting into a study. We're going to be looking at blood pressure. That could be an important trigger.
Yeah.
And then there's a third.
Yep. The Grenada Heart Project, presented by Dr. Samir Bonsalal from Mount Sinai School of Medicine. This was an intervention evaluating the effect of peer support among Grenadians compared with usual care on the effects on a lifestyle risk score called the BWAT score. And this was related to cardiovascular health metrics. And there was a modest, not statistically significant improvement in cardiovascular health using peer support. This was modeled after the 50-50 trial, which was performed in Spain, that did show an effect. And so there was a question of maybe that was due to a low amount of power. But I think the concept of peer support was brought to the table as an exciting way to think about how do we bring the community to help one another. Dr. Bonsalal used the example of within mental health for Alcoholics Anonymous as something that many people are very familiar with or understand that this is a successful program that's been used in many parts of not just the United States but around the world.
Yeah, I've been very much involved with peer support over the past year. And in China, for instance, there's a very successful program in the Anhui province where we've looked at diabetes and peer support. The key issue there is finding the peer to do the support. And in the Anhui study, there are actually community health centers. Interestingly, the older men who were retired were more likely to volunteer as peers than the women. They had family obligations. But when we get outside of community health centers, like say in Shanghai where we're doing it now, you really have to get out into a community and find someone who is competent and willing to work with patients who's had the disease, usually that's the peer, and can communicate both the patient and the doctor. So finding the peer turns out to be an interesting challenge. That said, I think it's the answer. I think involving the community, even involving the family in a patient who needs to stop smoking, change their diet, is critical. Don, your take on this?
Absolutely right, and I think that was actually a theme across these 3 trials that we saw this morning in this session, was even in the first trial, Dr. Peters' trial, they noted in a subgroup analysis that those people who enrolled in the intervention with their partner did better than those who enrolled without their partner, and true in the control group as well. So there is something about peer support, partner support, and our social networks that is very important in altering risk factors.
Now you also were involved with this very large database in Europe. Can you tell us a little bit about that?
Sure. So Dr. Stefan Blankenberg from the University of Hamburg presented data from the Biomar Care project. And what they've done is pulled together and pooled data from 12 cohorts to date, although they have plans for more. They did what's been done in England and in the United States to look at the lifetime risks of cardiovascular disease across these cohorts. So this is as I think I said in the session, this is a big data opportunity, but it's also a big data headache. What goes into data harmonization across these cohorts is not easy. But it's worth it because what comes out the other end is the ability to understand the life course of cardiovascular health and cardiovascular disease. And in this case, they were able to pull together data on 205,000 individuals from most of the countries, more northern than southern Europe, and define some of the overall lifetime risks for cardiovascular disease in men and women, but then also stratify and show individual risk factors do tend to stratify lifetime risk for cardiovascular disease moderately well. But when you look at the aggregate burden of risk factors, especially in middle age, we see dramatic stratification in lifetime risk. So people who have no risk factors by middle age have very, very low event rates over their remaining life course. People with 1, 2, or 3 have stepwise increases, and those who have the highest aggregate risk factor burden certainly are going to bear the biggest cost and have their events much earlier than those who avoid the onset of risk factors. So a very nice demonstration, I think, of the power of data harmonization, and we're hopeful it will be an opportunity for collaboration between Europe and the US going forward.
Certainly a concept that you've been very prominent in the United States in raising awareness. And I've noticed with the European Society guidelines that they now focus on, with the SCORE approach to risk, which is their current approach, showing patients how at age 30 with just a few risk factors they may be consistent with age 60 with only one risk factor. And so they're beginning to get the message, I think, that you've been so effective in emphasizing in the United States.
Well, I think that's where the frontier is. You know, I think one thing I'd love to see in the European guidelines is to get them moving off of just cardiovascular death as the endpoint. I think all of our patients would argue that there's more to life than cardiovascular death.
Certainly a stroke gets in there.
Absolutely
and
right.
I think the United States has made that point.
I think that's right. But you know, to your point, I think the frontier is at risk communication and risk perception. So we know that most patients aren't particularly health literate or health numerate. So providing a percentage risk probably doesn't work very well. So we need to find better ways, like vascular age, like using icons, green and red bodies, different ways to present risk to different types of people to try to motivate both behavior change as well as adherence to therapy.
So the overall take, you both have been very active in international work, and is it your feeling that the presence of these findings and this work at the American Heart Association scientific sessions is really increasing? And
yeah, I think 40% of attendees are from international, from outside the United States. I think Dr. Califf talking about information sharing being the platform for future innovations in cardiovascular research are borne out by this session. We see things from high-income countries and low and middle-income countries. So one of the co-moderators, Dr. George Mensah with the National Heart, Lung, and Blood Institute, talked about the Institute's emphasis on implementation science. How do we take the knowledge that we have that's been demonstrated to be effective in one setting, whether it be the United States or Argentina, and how do we translate that into other settings? How do we implement that? So I think that's actually an important part of global cardiovascular research.
Absolutely. Well, thank you very much. It's been interesting to learn about this, and I think this will be the beginning of many more sessions to come as we move forward in the coming years.
Thank you, Sid.